哦，大家早安。今天早上我们有两个题目，这两个题目都蛮有趣的。那第一个题目的话是由李炳勋医师他来讲一下，在 Level 1 osteotomy 之后 Scleral 的变化。李医师，请。
Good morning, professors, chief, and other doctors. I'm the 6th-year resident Li Bingxun, and today I'm going to present a journal comparison of scleral shell alterations following the 4-1 osteotomy with either maxillary impaction or lengthening. It was published on Journal of Cranial Maxillofacial Surgery this year. The 4-1 osteotomy is capable of altering the hard and soft tissues that affect the appearance of the upper jaw and cheekbones. It also assists in facial contour restoration and treatment of soft tissue discrepancies. In the orbital region, the position of the eyes, the interpupillary distance, and their visible parts are influenced by the relationship between the maxilla and the mandible, as well as by aging. On the other hand, if inferior orbital rims, malar eminence, and piriform areas are deficient, maxillary advancement is indicated. And for the inferior scleral shell, it can be defined as the visible white scleral portion between the lower border of the cornea and the margin of the lower eyelid. Ideally, there should be no more than 0.5 millimeter of scleral shell on direct forward gaze. Excessive scleral shell is a characteristic orbital feature of patients with midfacial hypoplasia, retrognathia, or endocrine orbitopathy. Surgical movement can lead to a change in the position of the movable lower eyelids and subsequently a change in the extent of inferior scleral shell. Scleral exposure alterations resulting from soft and hard tissue changes after orthodontic surgeries have been thoroughly investigated. However, only a few retrospective studies have explored the differences in such alterations following different types of Level 1 osteotomy. Thus, the purpose of this study is to evaluate the change in scleral shell after Level 1 maxillary advancement with vertical lengthening or impaction. It is a retrospective study from January 2014 to December 2018. The inclusion criteria is the OGS performed in a single center by the same surgeon. The exclusion criteria were incomplete virtual planning, inappropriate photographs, underwent malar augmentation, had temporal mandibular ankylosis, trauma history in the maxillary region, and craniofacial deformity. Subgroup analysis have been classified into vertical impaction and vertical lengthening. For the photographs, natural head position was obtained 1 month pre-op and 6 months post-op by the same camera mounted and placed at the distance of 1.5 meters from the patient at eye level. Swallow and blink twice was performed in order to relax the facial muscle and attain natural head position. Anatomical interpupillary distance is measured by drawing a line from the center of one pupil to the other pupil. Due to interpupillary distance remains a fixed anatomical reference before and after the Level 1 osteotomy. It was used for standardized pre-op and post-op photos. The scleral area between the landmarks was defined as the pixel number. For the details, A point is the outermost lateral point of the iris. B point is the intersection of a perpendicular line from point A to the true horizontal and inferior scleral border. D point is the outermost medial point of the iris, and C point is the intersection of a perpendicular line from point D to the true horizontal and inferior scleral border. For the results, 36 patients were finally enrolled in the study. For the impaction group, there were 6 male and 15 male with the mean age of 27 years old and mean impaction about 1.06 millimeter. For lengthening group, there were 5 male and 10 female with the mean age of 25 years old and mean lengthening about 1.54 millimeter. Age and gender distributions were not significantly different between the two groups. And there was no significant correlation between preoperative and postoperative scleral show and impaction, vertical lengthening, or anterior movement. The preoperative scleral show was significantly reduced postoperatively with the p-value 0.012 in both groups. However, the difference in the decrease in inferior scleral show between the two groups was also not statistically significant, though in this study, lengthening reduced more scleral show than impaction. For the discussion, inferior scleral show is an anatomical condition in which the scleral area below the lower border of the cornea is visible because of abnormal positioning of the bony structures that circumscribe the orbit, or the soft tissues that fill the extend the orbit structures. According to the results, level 1 maxillary advancement with vertical lengthening or impaction reduced excessive inferior scleral show, which correlates to the previous studies. Furthermore, calculation of the area provided more accurate results than linear measurements. That is to say, pixel count is better than millimetric measurements, since millimetric measurements are difficult to perform on standard photographs. Proportional measurements can serve as a viable alternative for determining the extent of the inferior scleral show. For the paper review, limited number of studies showing the effect of OGS on the extent of scleral show. Soiden et al. In 2014 showed decreasing in the inferior scleral show in maxillary advancement with or without superior repositioning. Postnik and Sami in 2015 show significant decrease of scleral show in maxillary advancement with impaction. Naruzzi et al. In 2018 showed maxillary impaction provides a greater reduction than maxillary advancement alone. And Tamasby et al. In 2019 showed 4.25% decrease among maxillary advancement and 3.65% decrease among maxillary impaction, with both being significantly effective. There was no previous data comparing maxillary advancement with impaction and with lengthening. According to this result, there was a decrease in the scleral show in both groups, but there was no significant difference between the two groups. The minimal movement in the vertical lengthening or impaction does not seem to have made any difference between the two groups. However, this needs to be re-evaluated in studies with an increased sample size. Furthermore, the authors plan to utilize 3D surface scanning and cone-beam CT to obtain even more comprehensive information about visible scleral changes after OGS, because this would help to measure the total visible scleral surface area 3-dimensionally rather than 2-dimensionally. Finally, authors also mentioned about the findings within this paper is only valid for movement less than 6 millimeters. And here, the authors try to explain the reasons for scleral show decrease. The possible reasons for scleral show decrease is that with an increase in the skeletal support to the soft tissue below the inferior eyelid and around the orbit, the eyeball can be pushed upwards, which helps correct undesirable and melancholic facial features as a result of a midfacial hypoplasia. And finally, the limitations of our study includes a smaller sample size and the lack of an isolated vector motion group, such as patients with only maxillary advancement. The other limitation is the accuracy of facial photographs, which are supposed to be taken in the neutral head position. This can be easily affected by individual factors such as exhaustion, insomnia, weight loss, or gain after surgery during the 6 months period. So The conclusion of this study is that the inferior scleral show is not a significant issue and can be reduced by Lefort-1 maxillary advancement, irrespective of vertical lengthening or impaction. And this would be all for today's presentation. Thank you.
谢谢李医师。请问各位医师有没有什么问题想要提出的？
May I have a questions?
Yes, yes.
English 还是中文就好？
应该中文就可以。
好 ，Sorry， 那个秉勋，我想请教他们收案里面有没有做 two 救，还是他们都只是做 one 救 Lefort 的部分而已？
他们好像没有特别提到他们是 two 救或 one 救，但是看起来他们既然是要 maxillary 的 impaction 或 lengthening 的话，应该会是 two 救。
对，因为你这个 table 上面秀的是 class 3， 那我们在临床上看到 class 3因为 mandible 也会 setback， 所以它 soft tissue 回去之后 sclera show 可能也会 reduce。那我们自己也有收这样的 case， 那我们是有分析它的 Lefort 跟mandible 的 relationship 之后去看它 sclera show 增加或减少了。那第二个部分它是用 2D 的 photo 去看而已嘛，对不对？
对，他说未来他才会用那个 3D 的 scanning 或 combing CT 去量。
OK， 好，了解了。OK， 那就先这样子。好，谢谢辉哥。
谢谢。
谢谢秉勋。
他的 follow up 是多久？
他没有特别提到他的 follow up， 但是他这个地方他比较的是6个月的之后的照片。
6个月之后的照片嘛。
对，他就是术前 pre up 跟 6 month post up 这样。
那周医师，你有提到说我们也有做一些 Sclera show 的 study 吗？
有。
那我们的 finding 是如何？
我们的 finding 是将 class 2跟 class 3的 case， 然后做 two 救 surgery 完之后去看它的 Sclera show， 但是在东方人 Sclera show 在80几个 case 里面，真正术前有 Sclera show 的不多，不像西方人那么多。那我们针对有这10几个有 Sclera show 的 case 再去分析，其实它 Sclera show 也是真的是减少，相对是减少了。那大众来讲的话，术前没有 Sclera show 的占大部分。那所以我是还没有将有 Sclera show 的这部分去做分析，反正我们只是分析说它整个术前的 eye opening 的 height 跟术后的 eye opening 的 height， 然后还有跟它原本的 double fold 双眼皮，那手术完之后双眼皮它的那个 height 有没有变化，我们是比较着重在这个部分。那因为临床上看起来似乎有一些护斗的 case 开完刀之后，发现他眼睛变大了，或者他的双眼皮变得比较宽了，所以想要知道说我们有没有这样的趋势，开完 OGS 完之后，让他的眼睛也相对是变得比较明亮这样子。对，但是现在分析起来没什么问题。
有没有差别？
现在分析起来好像似乎没有差别，好像没有差别。
所以还没有比较到术前术后的变化。
对对对对，现在还在分析当中。
那
我想请教，
部长请。
对不起，我想请教一下，我们病人在手术后有 complain 说 sclera show 多或少，对他的外观上有特别的影响吗？
我回答一下。那如果病人好像比较少会有 Sclera show complaint 的问题啊，就像说，我觉得东方人 Sclera show 会有的术前的真的比较少。那也许我觉得这好像比较常见在西方人 Sclera show 比较明显的，所以还好。对，
好，那这个部分应该是可以做一些 study， 但是不确定东方跟西方的之间的差异。那如果还有没有其他问题或者是 comment？ 如果没有的话，那我们就直接进入第2个题目。许医师。
好，方瑜，请你换你分享画面。
学长，我现在没有办法分享画面。
哦，那李医师要停止分享。李医师，
哦
OK， 好。这样，大家有看到吗？
有看到。
OK， 好，那我就直接开始。Good morning, everyone. I'm six-year resident Fang-Yu Hsu. I'm going to present this journal today. It's talking about the effects of throat packs during OGS. It's a double-blind randomized control trial published in International Journal of Oral Maxillofacial Surgery last year. Okay, the insertion of a throat pack after tracheal intubation has been used in nasal, maxillofacial, and upper airway surgeries. The function of the oral pharyngeal pack is to be a physical barrier to prevent the aspirations of blood, secretions, or fragments, and also to reduce postoperative nausea and vomiting. Post-op nausea vomiting is one of the most distressing complaints after surgical procedures under general anesthesia. Its occurrence increases post-op discomfort, decreases patient satisfaction, and may cause bleeding, dehydration, electrolyte imbalance, and also aspiration of gastric content. The average incidence of PONV after general anesthesia is 36%. In OGS, this rate is around 40% in single jaw surgery and 56% in two jaw surgery. The use of throat pack has been associated with an increased risk of post-op throat pain, damage to the adjacent mucosa during insertion, and the retention of the pack. And also make swallowing difficult. Post-op dysphagia with the delayed onset of oral intake may be related to the use of throat pack, the endotracheal tube caliber, cuff pressure, length of surgery, difficulty of intubation, and also lack of muscle relaxation for intubation. Some clinical studies that have evaluated the effectiveness of throat packs in nasal surgery and have shown little evidence of a benefit with their use. In OGS, although it is a common practice to use a throat pack, it appears that there have been no studies to justify their use. Therefore, the author designed this study to evaluate the effectiveness of throat packs in the prevention of PONV and to determine whether the incidence of sore throat and dysphagia are related to throat packs in OGS. The researchers follow the requirements for designing a clinical trial according to the consolidated standards of reporting trial. Physical status ASA 1 or 2 patients were included, and also age from 18 to 60 years old, and patients with indication for OGS, and those who has the full autonomy to decide on participation in this study. And they exclude patients with history of PONV, kinetosis, migraine, or difficulty in nasotracheal tube intubation, or allergy to the proposed drugs or some other complications that prevent data collection. Just a quick briefing about CONSORT. It's an evidence-based minimal set of recommendation for reporting randomized trial. It will help the study to prepare reports of trial findings, facilitate their completeness, and reduce the influence of bias, etc. All 54 patients were randomly allocated through the random.org program into two groups, those with throat packs and those with not. The patient sequence according to the randomization list was placed in an opaque and sealed envelope. The envelope was delivered by the evaluator to anesthesia team, who informed the surgeon whether or not to insert the throat pack. And during the whole procedure, the evaluator was stay outside the operating room. So patients and the evaluators were blinded. And all patients in this study underwent total intravenous general anesthesia by the same team, and to ensure adequate muscle relaxation during surgery. They use subsequent medication and doses of rocuronium with goal-guided and using the neuromuscular functional monitor. And tube number range from 6 to 6.5 according to patient's body height. And prior to intubation, the endotracheal tube was lubricated with lidocaine gel, and the cup pressure was standardized using a cup pressure gauge. And they use propofol in a target control infusion. And after induction, they use following medications for pain, edema control, and the formula for prophylactic gastric protection and control nausea and vomiting. And prior to the end of surgery, post-operative analgesia was performed with intravenous morphine. And for the reversal of neuromuscular blockade, they used Sugammadex. The throat pack used was standardized and consisted of 4 saline socket gauze in a row without a knot, and it was connected by a white cotton wire. This was applied under direct vision by the same surgeon to avoid trauma to the oropharynx. The surgical technique used for mandible was sagittal split osteotomy, and for the maxilla, level 1 osteotomy was performed. And if necessary, they will perform genioplasty for the patient. And the patient will be hospitalized for at least 24 hours after surgery. And the cold liquid diet was introduced from 3 hours after the surgery. Hydration was performed with ringer lactate administration, with the daily volume calculated according to the patient's weight and the blood volume loss during the surgery. And ondansetron and tramadol were rescue drugs for nausea, vomiting, and post-op pain. They collect patients' demographic variables, and the variable pain was evaluated and recorded at 2 hours, which is T1, and 24 hours T2 after tracheal intubation using a visual analog scale. And to facilitate the visualization of the results, the author divided the pain scale into 4 categories. 0 is no pain, and 1 to 2 is mild pain, 3 to 7 equal to moderate, and 8 to 10 was severe pain. And for the dysphagia, it was evaluated at T1 and T2, and the criteria was difficult swallowing the liquid. The patient were assessed for the presence or absence of this symptom, and the PONV was evaluated in the first 24 hours after surgery with Cordilla scale. Cordilla scale divided post-op nausea vomiting into 4 levels: no nausea, or mild, moderate, and severe PONV. Statistics was SPS was used for statistic analysis, and the author will perform a normality analysis first to decide the analysis method. And the inferential statistic was performed with Pearson chi-square or Fisher's exact test. This is the flow chart of patient recruitment into the study according to the council statement. 76 patients were enrolled and 22 were excluded because they did not fit the study criteria. And 2 patients in each group were lost to follow-up and were excluded from the data analysis. And therefore, a total of 50 patients were included in the analysis. And all 50 patients included underwent sagittal osteotomy, and the 47 patients also underwent a level 1 osteotomy, and 29 patients underwent a genioplasty. 27 patients had a sore throat, and 18 in the group with a throat pack, and 9 patients in the group without a throat pack. There was a statistically significant difference in throat pain at T2 between the 2 groups, and the patients who had intraoperative throat packs had more dysphagia with a significant difference at both times. From the histogram, 24 patients had no sore throat at T1, while 31 patients had no sore throat at T2. pain intensity ranged from moderate to severe with no significant difference between the groups at T1. And the post-op vomiting rate in this study was 24% with no difference between the groups. And the post-op nausea rate was 34%. On the Cotilla scale adopted for PONV, 64 patients had no PONV, 26% had mild PONV, while 6 had moderate, and 4% had severe PONV. However, there was no difference in these rates between the groups. And this table shows post-op vomiting and post-op nausea according to blood loss volume, duration of intervention, and opioid use. It was observed that the duration of surgery did not influence the occurrence of POV and POM. Patients who used post-op opioid had higher chance of post-op nausea. And then this is a group without throat pack, which had a similar result. Patients who used post-op opioid had higher chance of PONV. And 83% of the patients who had vomiting used opioid for post-op pain control. And similarly, 76% of the patients who had PON used this post-op opioid rescue analgesic. So one of the reasons for use of throat packs in OGS is to minimize the inflow of blood to the stomach and reducing the frequency of PONV. The real effectiveness of throat packs in preventing PONV is in nasal and upper way surgeries. However, the effectiveness in OGS is not proven yet. Other factors are related to PONV too in OGS, such as their gender, duration of surgery, inhalation anesthesia, and post-op opioid use. And the PONV rate in the first 24 hours was 36%, which was lower than previous study, which was found maybe related to the use of total venous anesthesia. And the author also includes patients with history of PONV. And there was no difference in PONV rate between the groups. The post-op nausea rate was 34% and the post-op vomiting rate was 24%. These rates are lower than those found in studies evaluating nausea and vomiting in OGS. And intraoperative blood loss volume in this study was higher when compared to the average reported in a systemic review published in 2011. In this study, 75% of the patients who vomit in the study had the blood loss volume above 500 cc. Previous studies evaluating the risk of PONV in OGS have not considered this parameter. And the dehydration or electrolyte imbalance may have been the factors related to vomiting in patients who had blood loss greater than 500 cc. Therefore, the author proposed that the estimation of intraoperative blood loss should be included in studies that aim to evaluate the risk of PONV in OGS. And an excessive tracheal tube cuff pressure decreased local perfusion in the tracheal mucosa and will increase the inflammatory response. In this study, the frequency of sore throat was 54%, which was higher than previous study. And this difference in frequency could be attributed to the longer duration of the surgery in the current study. The frequency of sore throat was 72% in the group with a throat pack compared to 36% in the group without throat pack. And there was a statistical difference and higher intensity at T2. And a relationship between post-op dysphagia and the presence of throat pack was identified in this research. However, a limitation of this study was the difficulty in measuring this parameter, since patients undergoing OGS usually have post-op difficulty in swallowing. Nevertheless, there is little information in the literature on the subject and few reports on the persistence of dysphagia during the post-op period. The overuse of throat packs could result in some complications. There was no evidence or complication related to the use of throat pack in this study. However, tongue edema, pack retention, and even death has been reported. They also suggest that the exchange of throat pack during surgery should be avoided, and the inspection of oropharynx before tracheal extubation should always be adopted. So they also conclude that this study showed the use of throat pack in OGS undergoing OGS had little to no benefit in decreasing PONV, and the patients who had the throat pack more often had a sore throat and dysphagia. Thus, the routine use of throat packs in OGS should be avoided. And if this is not possible, individualized for the patient is necessary. This is the end of my report. Thank you for listening.
好，谢谢方瑜。那请问各位医师有没有什么问题或者是 comment？ 诸位请。诸位您的麦克风。诸位您麦克风要开。
在左下角。
那个我要问一下，这个是哪一个 center 出来的？
这个是我记得是巴西的一家医院，我看一下，它是巴西的一个叫 Federal University， 这看懂吗？我看看我可以分享我的荧幕。
好，没关系。我看到它 PONV prevent PONV 的 protocol 和我们的很相似哈。
对。
那第二个是他开的 double jaw surgery 的比例也蛮高的，那开刀时间也是和我们的很类似，那只有 throat pack。好，那么但是它的 PONV 的那个 total 36% 算起来还算蛮高，比我们还高了。我们大概上次苏西令报告大概只有17%。那你认为到底我们和他的 procedure 有哪个地方不一样？为什么我们会稍微比他们低一点点？
从他的这个我那时候有想了一下，其实我也觉得蛮奇怪的，因为他的就是手术时间，然后用药 blood loss。就是我虽然没有看过我们这边自己的 data， 但是看起来好像都跟我们的很接近的感觉，所以其实我也觉得我也没有办法找出说特别哪里为什么会他们的比较高，但是我后来有再去看一下其他篇，其实我觉得这个大家做出来的结果好像都会有一点点差别，就像昨天review 的 PONV， 我有看到另外一篇就是说它比较。就是两组都用 throat pack， 只是里面有一个是就是 normal saline， 一个是有 NSAID 的 spray 在里面。它的 PONV 的 rate 其实我看一下反而比这一篇还要低，但我也不知道为什么。就是我觉得这里面每一个 surgeon maybe 在操作或者是什么，会不会有一些其他的因素，我们就是 study 目前都还没有特别讨论到的。就我觉得大家虽然 standard 看也都差不多，可是结果数值上来说都会有一点点差别。
大概我可以想得到一个是，他似乎没有提到 local 的 block， local block 他没有提到，看起来他有 local anesthesia， 但是没有讲到 local block， 因为 local block 本身确实会降低很多。那第二个是 opioid， 我们是几乎都不用，那痛要止痛用 opioid 的话，一定会增加，这个 opioid 你几乎都没用，这个东西大概这两个。那我本来以为这个study center 是香港那个，因为在香港的他们做 OGS 的时候，几乎把每个 case 当做 case study 来做protocol 来做。我想以前是那个林教授在的时候， 不过可想而知，在一个 center 里面，事实上都可能可以做所谓的control study， 因为我们的都完全一样 protocol 之下，事实上只要一个 variable 的时候，是可以做类似这样的 study。我是觉得说，哦，它的 protocol 很像我们的，但是有几个不一样。那这个是什么？我们可以来说一下。不过 anyway， 我们再问一下，是说到底我们科里面有多少人还做 slope 那个的 packing 的，有吗？我知道我也做过几次，但是我觉得我不喜欢。那我不知道，我知道我们几个同事有的还在做。
所以我们在那个在麻醉开刀前会在喉咙塞一块纱布，那叫 throat pack 吗？
是啊，
定义上应该不像吧？
口腔外科他们塞的可能比我们的还大，但是看你有什么怎么，就你一块纱布你要多大？它显然是用蛮大的，因为它有一条连到外头来。
他说这里塞了4块，那我们塞1块是因为怕我们的矫正器松掉掉进去嘛？我们的目的是这样，而且只塞1块，是没有太多嘛，哈，我也没有说塞得很紧嘛。那所以这个 paper 建议说以后就不要塞了，可是，在我们的习惯上，好像就是塞一小块4×4纱布放在里面，因为我想我也有矫正器掉到喉咙的痛苦经验，所以我都还是习惯会放1块在里面，可以保护。那我是这样想法，可是我没有塞到那么像他用4块纱布塞的那么紧啊。不过我觉得这个 paper 给我们的一个观念就是说，为了避免血液跑到胃里面，塞这 throat pack 似乎好处并不很大。因为我以前一直还记得说，以前我在跟罗院长的时候，在开小 baby 的唇裂或腭裂，常常会在口腔里面塞了2大块的4×4纱布。那当然一方面是避免血液流到胃里面，但另外一方面是为了 stabilize 它的管子，让它管子，因为它小宝宝没有 cuff， 是为了让它的管子比较稳定，是这个目的来用的。
对，那个为了固定那个 endotracheal tube， 尤其那个小孩子在那个地方手术，事实上以前我也这么用，但是现在 OGS 来讲，第一个如果是要 prevent 那个 blood 到 stomach， 似乎效果不一定好。第二个，它产生的确实 throat pain， 我塞了几个，大概 throat pain 的机会比较大，就像这个 study 一样。那 over 来讲，以前曾经发生过的就是麻醉科的疏失，那个 pack 没有拿掉，也就是说真的是没有拿掉，那个真的要为的在以前有报告过，这个在最讨厌的事情就是说你没有拿掉。那其他地方的目的，我相信为了固定 tube 啦或怎么样，这个我想是可以理解，只要这 pressure 不要那么大，应该没有什么坏处。不过记得一个原则，真的不要忘了拿掉，或者拿不干净。
方宇，我可以请教你一下，就是他有没有提到手术时间长短？对，
它里面有跟其他的，它这里面有列出来，其实它2组是没有差别，可是它有提到，它跟其他就是刚刚他有提到一个，后面 discussion 有一个它的nostril vomiting rate 稍微就是比是讲是痛的这个地方，他说比就是之前的手术还要长一点点，所以他觉得 maybe 他们这个 study 里面比例比较高一点点的原因，有可能是因为这一篇手术的时间比他前面就是 review 里面看到的多一点点，但是2组来说是手术时间是没有差别的。
他平均是几个小时呢？
他的平均大部分我记得大概4个小时左右，220到250分钟左右会结束。
因为在 throat pack 来讲的话，第一个考量的是说它到底塞了多少进去。那塞越多，当然它的塞得越紧的话，它的 pressure 的 effect 在时间越长，应该是会越有一个 side effect 出来。那他又特别强调说，在 手术当中完全不能够换不能够换这个 throat pack， 所以等于说，因为像我们的病人，我们都会注意到说，过几个小时我们就要移动他的身体啊，帮他做按摩啊，所以这个 pressure sore 是不是会造成pressure 的 injury 是不是会造成喉咙的疼痛？这个可能也是一个因素。
对，因为像他也没有特别到，就是他术后会喷喉咙的喷剂，可是其实我们的病人有，所以我觉得我们 maybe 其实我们有一些 protocol 其实之前也不一定有人 study 过 ，maybe 也可以用类似的方法来做 study 这样。
是，
像昨天我们在讨论那个所谓的 packing 用什么样的药，忘掉是什么样药。
他也是用那个，他的也是一个用 normal saline， 一个是用就是那个 benzodiazepine， 就是我们现在在用的喷剂，然后加上 chlorhexidine， 它就是这两组去比较，两组都有 packing， 只是 packing 的 solution 不一样。
那结果是？
它的结果是，就是如果有使用的 NSAID spray 的那一组，就是术后的，就是 sore throat 是有 significant 的 difference， 是有很明显的改善，但是 PONV 两组是没有差别。
所以看起来 packing 是不好，但是在 throat 方面喷一些止痛剂应该有效，这个倒是。
对，从昨天那篇 review 看起来，我觉得我有再把它找出来看起来那个 NSAID 的 spray 看起来是好像蛮有效的。
好，倒是可以 study 的，就是说 NSAID spray 的时间是什么时候？比方说是在 post-op， 或是在 during surgery， 或是 pre-op。就像我们给的 NSAID 一样，我们 NSAID 也有给的是 post-op， 已经痛了以后再给。那另外是不要痛以前先给。那么这个来讲，我想大概有点帮忙。不过以这个 study 精神来讲，如果它这个是巴西这样设计，以我们现在都 routine， 大家都是做这样的时候呢，也许就某一个组，比方说我们哪一个组呢，就做一个 control study， 一个这样子，一个另外一个同一个 surgeon， 然后有不同的做法，就是一个 study。所以这个倒是我们可以学的地方。
对，
方宇，我请教你一个问题，你跑回那个randomized trial 的设计
randomized trial
console
不是它的数目字
console
就是分
它的数目字，你有一个
这个，
对，它这次 randomize 是你说它是从一个袋子里面去抽yes or no 这两组是？
它是用一个，其实我后面有最补充，它是用一个这个 website， 这个 website 好像已经蛮多人知道，它就是专门帮人家做 randomize 的分析，它里面有很多种，你也可以用。
不是，它是怎么样去把病人 assign 到with or without 这两组？
它是用这个网页，它有一个它设计出来的就是把它做 randomize 的一个 program， 所以它就把这些病人全部，比如说54个病人，他就丢进去，然后用这个软件可以把它设计，你要把它分成两组，或是你要像什么骰子或者是抽签的方式，它可以依照你想要的方式来帮病人做乱数的分析。它是很均匀的分成两组，
它的 randomize 是很均匀的分成两组是？
对。它就是看，它是这个软体就是看你的需求，你可以比如说你要分成6组或者是2组，它有不同的设计。那这个我有查一下，它是用什么大气的噪音去抓那些 radio 的 noise， 然后所以这个目前是被大家认为说是最nature 的一个软体。
你这个好像讲的好像有一点天马行空，不过你再回到那个数目字去，因为我好奇就是说为什么数目字都是刚刚好，是说它的设计的用意就是很均匀的分成两组就是了，是不是？
对。
因为一般的 randomize， 如果我们说从一个口袋里面抓2个铜板 yes or no 这个的话，常常不一定会数目字刚刚好。你看27、25、25。log follow 甚至是2跟2，这个怎么会这么漂亮的数目字？
对，其实我那时候看这个，我也觉得有点巧，就是它2组都是刚好都是2个人，我也觉得
数目字漂亮到我觉得，这到底是在玩真的还是玩假的？这个有时候一个 randomized trial， 你看到数目字都这么漂亮的时候，你说又是巴西出来的，它到底是有没有什么 trick 在里面哈？所以我们常在看 paper 的时候要很小心的去看它的。
是。
因为而且他说他是 medical center， 像 只会讲我们已经不用 opioid， 你知道 opioid 就是会造成 nausea vomiting， 为什么还用
它是 trauma 的，不过它那个是 rescue 的，它并不是 routine 的，它 routine 其实这2种都是 unsafe， 只是病人就是很痛说他才会就是 upgrade 到就是 opioid 类的药物。
OK，
不然他 routine 的病人给的这2种口服还有 IV form， 这个也是我们在用，都是 NSAID 类药物。
好。
好，请问各位医师还有没有其他想要问的问题？张医师在吗？
你说新哥是？
哎，新哥，
我刚刚好像看他的名字啊。
新哥在。
有了，他名字在上面。
好，大家还有没有什么问题或者是要追加的？那如果没有的话呢，那我们今天的 morning meeting 就先到这里为止。那在这段期间的话，希望大家持续保持安全。那期待这个疫情赶快过去。好，谢谢大家。
谢谢。
好，拜拜。
今天上班太忙碌，因为大家混乱之中。好啊，这个对。
你帮我定一下，谢谢。
好。哎呦，来